Good morning, everybody. We're going to get started. Thanks for joining us. It's my pleasure to introduce Dr. Pilar Pichon. She is a child epileptologist at Loma Linda University, and she's also now starting at CHOC tomorrow. Is that correct? Her special interests include status epilepticus in sleep, epilepsy surgery, and autism. She did her clinical neurophysiology fellowship at Emory University in Atlanta and her child neurology training at Loma Linda University. And it is my pleasure to introduce you.
Hello, everybody. This is my largest crowd yet, and I'm happy that you made it. So today is my last day at Loma Linda, and then tomorrow I start at CHOC. So this is a great welcome here in Orange County, and I think at this point of transition in my career, I was at Loma Linda for 13 years, and then now I'm starting at CHOC. I asked myself last night that if this was the last talk that I can give, what are the things I would like to share with you? At least the three big things, three big regrets, or three big guide. I have learned a lot from my patients' parents and from my patients. They have given me as much as I have given them, or even more. And so one of my passions are the treatable disorders and the things that are often undiagnosed or misdiagnosed or diagnosed later. And ESES, or electrical status epilepticus in sleep, is one of them. And if they're not diagnosed, the impairments that the child presents, they don't go away. So you have that window of 2 years when you can intervene. And if you intervene in 2 years and you diagnose the child correctly, you treat the child appropriately, then there is a big chance that a lot of the impairments, the difficulties, the learning difficulties that the child is having, as well as the seizures, can be treated. So that's why I chose this talk. And also, I have a big interest in children with developmental disorders like autism. And my hope is that somewhere down the line, I really believe this, that we can use ESES as kind of like a model. If it is treatable, then I think my life would be worthwhile if there is a way for us to use things that we learn in ESES in treating children with epilepsy and treating children with epilepsy and autism. So the three main objectives, I wanted to define to you what ESES means, what CSWS means, and I know there are a lot of acronyms and letters soup in your head, but ESES is pretty popular, so I think if you Google it, you'll find it. And this is an EEG pattern. So the epileptologist in the group will tell you it looks like there's ESES on the EEG. And there's a new name. Every few years we come up with a name for a disorder. Now the new name is developmental and/or epileptic encephalopathy with spike wave activation in sleep. It's too long to remember, right? So just say ESES and people will know what you're talking about. And what it means by marked sleep potentiation is that when the child falls asleep and as they go into slow wave sleep, they go into electrical status. So the EEG, you just see these bursts of discharges. And near continuous, so it's very hard to miss. If you do a 24-hour video EEG, you can see the near continuous runs of the what we call spikes and waves. So spike, I tell people you don't want to sit on it because they're sharp. And like autism, it is a spectrum. So ESES, there's, some of you may know about benign Rolandic epilepsy. So it could present initially as that, or some of you may know about Landau-Kleffner or have heard of it, or continuous spike wave in sleep. And continuous spike waves during sleep, think of it as like the umbrella diagnosis. So let's say a child has autism. A child may have repetitive behaviors, may not be able to communicate well, may not be able to socialize well. So the diagnosis overall is autism. And then think of ESES as over that is the CSWS umbrella. So continuous spike wave and sleep and waves during sleep. Anytime they say it's a syndrome, it's usually an umbrella diagnosis where there are characteristics underneath it, okay? And it may be difficult to control the seizures if they have seizures at night, mostly at night, but if they do have seizures during the day, it may also be very difficult. And unfortunately, the pattern on the EEG that you initially see, even if the child gets better, let's say 2 years down the line, the EEG pattern may still persist, and the global regression, the delays that they came with, it may still persist, and the neurocognitive regression. So most of these kids are normal from age 1 to 5. And then ages 6, 7, 8, then the parents start saying, oh, they're not paying attention in class if they go to school, or they're very hyperactive, or they're not learning the things that they used to do, they're not able to do now. And the epidemiology, meaning how common is it? So as I told you, they can start at 2 to 12, but most of the children I see are between 4 to 5 years old. In outpatient pediatric series, 1 out of 440 of children with epilepsy had CSWS. So even if they already have a diagnosis of epilepsy, there is still a possibility that this falls under the umbrella of CSWS. And then in tertiary pediatric epilepsy centers like CHOC, where I will be heading to tomorrow, and Loma Linda, the incidence is a little bit higher, about 0.6% have CSWS. And in a large case series, they saw that male patients have a higher incidence of the CSWS, about 4 to 3 to 3 to 2, compared to the females. So what do the seizures look like? Sometimes they present at 2 to 4 years old, and sometimes if you do an MRI of their brain, you can see abnormalities in the structure in the brain. And so there are, just like as I mentioned, it's like a spectrum. There's a mild, severe, and a presentation. There are also stages. So when they first come in, seizures occur out of sleep. So some parents can miss it because they're sleeping, and we don't always watch the kids when they're asleep. The seizures may be tonic, so they get stiff, and then clonic, or tonic-clonic unilateral, so just one side. And so that's another thing. It may also be easy to miss if you're just looking at one side. So I present to you a case of a girl who was 7 years old when she came to me. She has infrequent seizures, about 6 seizures per year. But then what the mom noticed that was, she just could not let it go, was she started to have memory problems. And I asked the mother, what are her seizure types? So she would have the behavioral arrest, and also left motor clonic seizure, so twitching of the left side of the body. And then the other description of her seizure is, this is not really, it's not something that, if a child starts to act funny, we don't always think, oh, it's a seizure. But that's how the mother described it. She acts funny, she stops talking, and then the left side of her lip starts shaking. And then her left eye winks, her left hand shakes, and the left leg shakes. So it's all on the left side of the body. So when I got more history, she had a tumor. It's a right atrial choroid papilloma, and then that tumor was removed at 1 year and 7 months. And there was a complication of an intraventricular hemorrhage, and it required a VP shunt. At that time, she had her first seizures after surgery. So she was placed on Keppra and phenobarbital, which is a common combination for this age group. And then she was eventually weaned off the Keppra and the phenobarbital after being seizure-free for 2 years. So our old goal, we always tell families, seizure-free for 2 years, and then we can stop the anti-seizure medicines, which the referring doctor did. So this is just a reminder of the stages that I was telling you about. She is probably at this prodrome stage, the clonic, with the clonic seizures. And then once the child starts having different types of seizures, by the time she came to me, she was already in the acute phase because she would have these spacing out. So absence, and then they can have absence status epilepticus, meaning prolonged spacing out. Atypical absence, the pattern that we see on the EEG is not your classic 3 hertz spike and wave. It may be slower. And then the atonic seizures is when they start to either do head drops or their body drops, or they would just fall. So just as a recap of her presentation, seizures around 2 to 4 years old, and then she had regression around 5 to 6. And in her case, when I did the EEG, it was also worse than her EEG prior to stopping the phenobarbital and the Keppra when she was seizure-free. So in some children, there is a gradual resolution of seizures and EEG abnormalities at 6 to 9 years old. So that's why I put this here, because when you reach 9 years old, it's good to breathe a sigh of relief and say, oh, my child is no longer having seizures. But the parents will ask, why is my child still having memory problems? Why is she still hyperactive? So the persistent neurocognitive deficits, that's what we want to prevent from happening. When they're awake, you can see focal, multifocal spikes, and then they increase once the child falls asleep. And sometimes they can have continuous bilateral, meaning both sides of the brain, or occasionally it would just be one side slow spike and waves, which occur during a significant portion of the non-REM sleep. So what the non-REM sleep means, that's the slow wave sleep. It's different from the REM sleep, where they have the REM stands for rapid eye movements. So it's a big chunk, it's a big portion of sleep when they have these spike and waves. That's why some of the children have memory difficulties, because the non-REM sleep time is also the time when we try to consolidate, meaning to solidify the things that we learned during the day. So when they're seizing, instead of consolidating their memories, of course, they won't remember much the next day. And these are just for the EEG readers in the room who are interested. We actually sit and count the spike wave index for a certain period of time during the non-REM sleep. And then now we have programs that do it for us, so it's much easier. So when I read an EEG that says this was an ESES patient in the past, I try to put a spike wave index. That way there is a point of comparison in the future and in the past if they obtained the spike wave index during the previous EEG. This is just an example of the EEG. As you can see, a lot of sharps, right? And it's very continuous. So how does it evolve? I keep harping on this because it progressively resolves, but then you may have seizure freedom, but the neurocognitive deficits can persist. Sometimes they may not have deficits. They may have what we call plateau in development. So they are not acquiring the skills. Some patients can remain severely impaired, and there are studies to see if you count the spikes that I showed you, if there are more spikes, what does that mean in terms of their neurocognitive features, in terms of their ability to learn things, to remember things. And I think just from the past 13 years, from reading EEGs and seeing the profiles of these children, it really does affect it. The more spikes you see, the more seizures you see, and as parents, you know that. They don't learn as well as children of the same age. The etiology, meaning what causes ESES, in some cases it's unknown, and it's called non-lesional cases. If you do an MRI, you may not see any structural abnormality. But there is an association of CSWS, the umbrella diagnosis, with early developmental lesions of the brain. And so this knowledge kind of helped me narrow down my thinking for my patient. And also there may be genetic associations. So this is another alphabet soup. And I think of it, the most common one I've seen is the GRIN2A. Unfortunately, the way I remember it is if you have a GRIN2A mutation, it may not be a good reason to grin, because then that could be causing the ESES and the frequent seizures. And one of the most challenging patients to work with are the ones with deletions in their chromosomes and duplications. So I sit down with the families and I talk to them. This is what's been reported about the expectations that we can have for a child with this deletion. Number one, do they survive? For how long do they survive? Do they get to go to school? Do they need special help? So we go through all these expectations of what's been reported. But just like in the autism world, when we say, you see one child with autism, you've only seen one child with autism. And I think it's the same. For a child with epilepsy, you've seen one and you've only seen one, because every child is different. But my motivation in life is to help them be the best that they can be, whatever that is, whatever goals the parents and I set. Let's try to meet that. So malformations of cortical development have been linked with ESES, and other types of lesions, especially the thalamic lesions. So this got me very excited when the DBS, the deep brain stimulator, got approved for epilepsy. It was always my question in the back of my head, could we treat these children who are not responding to the conventional treatments with DBS? And vascular insults. So if the children have had strokes before, for example, or bleeds in the brain, they may also have ESES. And perinatal thalamic lesions. So there's that thalamus again. Think of the thalamus as kind of like the airport hub, you know, where the 405, the other freeways cross, the thalamus is like that. So the more cars cross on those freeways, the more chances of accidents. It's the same in the thalamus, unfortunately. It's a freeway. So that's also where vascular insults can happen, perinatal insults can happen. So going back to my patient, this is how her MRI looks like. And that area where the whitish area, that's the encephalomalacia. So what we did was we put in electrodes, the depth electrodes, in the area where she had her previous surgery around it. And then we also put in electrodes where some of her interictal spikes, meaning the spikes on the EEG, can be seen when she's sleeping. My hypothesis I think it's just coming from the area where the scar tissue was, from where the surgery was. But at the back of my mind, her presentation was memory problems. I'm like, I think this involves the temporal lobe. Because remember, the temporal lobe is responsible for memory. But you cannot convince the neurosurgeons, right, without you proving it to them, this is where the seizure is coming from. So after we did the SEEG, surprisingly, the seizures were indeed coming from the temporal lobe, not from the scar tissue. So I tried her on all these medications except for IVIG. I tried her on high-dose benzos, clobazam, diazepam. I tried her on anticonvulsive drugs. I usually start with very high-dose Keppra, 60 milligrams per kilogram per day. And then I tried her on steroids. So her EEG would get better after 3 months. And then after 3 months, the status comes back when she falls asleep. So the way we think is we do not keep doing what does not work, right? So you escalate the treatment. And we got to that point where the mother was saying, well, what's our next step? What's our fourth step? And I said, let's take a look back. And then that's when we did the epilepsy surgery evaluation. So these are just the findings about the medications. So the levetiracetam, that's the one that I use usually as first line. In a study of 17 patients, it was effective in 7 out of 17 patients. And then the second line that I do is clobazam. So in a study of 19 patients, it was effective in 6. But as you can see, from 41% effectiveness down to 31%. And then the steroids, it has a higher cure rate or remission of the spike and wave pattern on the EEG, 11 out of 17, which is 65%. But based on my experience, after 3 months, it goes back. The other medications, valproic acid, lamictal, topiramate, and ethosuximide, they have not been found to be effective. So going back to her case, as I told you, she was on valproic acid before. I started her on high-dose Keppra, clobazam, Valium, and then the rescue medicine for Diastat. With the Keppra, just like other children, she became very aggressive. With the Topamax, she became very dopey. Her memory was even worse, so I took her off of the Topamax. I lowered the dose of the Keppra. And the valproic acid, no change. So my experience with her is the same as the experience in other centers. Usually, so what was my conversation with the mother? I told her that the duration of the regression period can be between 2 months and 5 years. And the correlation between the length of the ESES and the period of residual intellectual deficit at follow-up is directly related. What that means is if you do not intervene, it may stay. The deficit will stay. And with children who were treated less than 13 months, so this is even a shorter period of time, than what was reported by Kramer, which was 2 years, there are no residual intellectual deficits in patients who were treated aggressively within 13 months, okay? Surgical treatment. So these were reported, MST, lesionectomy, hemispherectomy, and the treatment pattern, usually there is an ESES resolution or reduction of the spike wave index to less than 50%. And it can actually last up to 17 years. So some children could present later, and this has been surprising for some because we always thought that it remits by 10 years old. Relapse rate is higher for steroids, so 89% for steroids. And then benzodiazepines, 60%. Anti-seizure medications, 29%. And the thing is, ESES in sleep resolution, if you stop the status epilepticus in sleep, the child will be seizure-free also when they're awake. Going back, let's revisit the spectrum. So Beck's, Landau-Kleffner, CSWS. I think my patient had CSWS, so she had the very severe type. And these are just the description of this spectrum. I'll just go over, and this is what the EEG looks like for the Becks. This is the Landau-Kleffner. The key to Landau-Kleffner is language regression. So they have receptive mixed aphasia, and they have verbal agnosia. That's why there's sometimes misdiagnosis. Maybe they can't hear. That's why they're losing their language skills. For Landau-Kleffner, they have infrequent seizures, and the epileptic focus is usually in the center temporal and posterior temporal or parieto-occipital. So this is just the pattern of the EEG for Landau-Kleffner. And then for the CSWS syndrome, this is what my child had. Global cognitive deficits, they can have motor disturbances, and most of the epileptic focus comes from the frontocentral, frontotemporal, centrotemporal, and frontal. So think about front, center, temporal. And this is the EEG for my patient. So it's continuous. You have these spike and wave, and throughout non-REM sleep, this is what it looks like. And this is just a comparison of the Landau-Kleffner and CSWS. I can share my slides so you could review it at your leisure. See how in Landau-Kleffner, 50% are hyperactive, impulsive, and aggressive. So how many kids do we chalk it up to ADHD? But then if they have seizures, if they're not sleeping well, if they have any verbal or auditory agnosia, they don't understand what they used to know whenever they hear something, then think of Landau-Kleffner or think of CSWS. Actually, in CSWS, 100% of them have hyperactivity, impulsivity, and aggression. So going back to my case, we did the stereoelectroencephalography, and we saw that the seizures were coming from the mesial right hippocampal electrodes, so that's where the temporal lobe is, away from the scar tissue from the previous surgery. So our neurosurgeon did a right frontotemporal craniotomy and did cortico-amygdalo-hippocampectomy. It's quite a mouthful, but basically he just took the tissue that had the part of the cortex, the amygdala, and the hippocampus. Big chunk of temporal lobe. And her outcome, she's been seizure-free since surgery. Her memory and learning has improved, and she was just this precocious little girl. I gained a little bit of weight. She looks at me and she's like, "Doctor, are you pregnant?" And I'm like, "No, it's just turkey fat." That was after Thanksgiving. But she's been doing so well that I only get to see her once a year. And Mom is very happy. So this is what her MRI looks like now. That's what it looks like. So if there's anything that I want you to take away from this talk is that ESES is an EEG pattern, CSWS is the syndrome. The window of opportunity is 12 to 18 months. And you know your children best. You are with them for 24 hours a day. We are with them during the visit. So we will listen to what you see. We will listen to what your thoughts are. And a longer duration of ESES may be associated with poor cognitive outcome. So if I can just help one family, one child, prevent the poor cognitive outcome, I've done my job. Behavioral abnormalities, particularly hyperactivity, are commonly present in ESES. I think if there is no family history of hyperactivity, for example, there was no risk like prenatal exposure to drugs, I think this should be on the differential. And if there is epilepsy, if there is an abnormal 24-hour video EEG, this should be on the differential, meaning the things that we think of, okay? These are the references as well. If you want more information, you could certainly go to the primary articles or the text. So now I want to, this is an Ask the Expert session. I don't claim to be an expert. I am still learning. I'm very enthusiastic at teaching. So I have to teach my residents, my fellows. So I have to keep up to date. But if you have any questions for me, I'll be glad to answer them. Yes, ma'am.
So there's a group of parents right now trying to start an ESES foundation.
Oh,
And
wow.
one of the things that we're trying to do is that we're wanting anybody who's been diagnosed with autism to get an overnight EEG. Because my son was told, oh, his behaviors are just autism. Well, now he's 6 years later, his IQ has dropped over 30 points. And it's been pretty rough. So I don't want any more kids being told it's just autism. Because please dig, please dig. If the kids plateau, or if the kids have regression, or any kind of altered mental status, they need an overnight EEG. Not this 5-minute one, or 30-minute one, whatever it is 45-minute. They need something longer. And somehow we gotta fight the insurance company with that, like now. And also, they need a baseline, as soon as they have a diagnosis of any seizure disorder, they need to have a baseline neuropsych, because that's a way to determine any regression if that's occurred. And then the time of each of those trials, the time that they tried out zonisamide and clonid this and that, his brain was being ravaged the whole time. It needs to be faster. Like, within a week, we should know if it's working or not, somehow, some way. Not like 6 months of steroids and then, oh, we stop and like, oh, he's back to status again at nights. Like, it's got to be a little faster than what we're doing, what we've been doing. Because, you said you were like, first we tried this, then we tried this, then we tried this. Is there a way we can speed that process up?
So that is a very good question. When I was training at Emory, my older attendings would always frown at me because I always asked for an epilepsy panel or some type of genetic testing, chromosomal microarray. And in Georgia, it's a lot more challenging than California to get any type of genetic testing done. But to me, one of the faster way that we could find etiologies of epilepsy, for example, and autism, or epilepsy and autism, is to do testing that have high yield. And one of them, so MRI has been reported to be the highest yield. And then genetic testing, if I'm suspicious that this is one of the genetic epilepsies. And if I'm suspicious that this is something that's a combination of a neurodevelopmental, meaning a cross between autism and epilepsy, I usually do either the neurodevelopmental panel or the chromosomal microarray. And of course, if they have seizures, in my ideal world, everyone present with seizures, who have autistic features, who have developmental regression, should get a 24-hour video EEG. I agree with you on that. But the battle has been getting harder and harder, especially against the private insurances, because they would not approve a 24-hour video EEG unless they had a routine EEG or a 2-hour EEG. And then, even if it's abnormal, they won't approve a 24-hour video EEG. They will approve an ambulatory EEG. So I fight with them at least maybe once a week. I get into these peer-to-peer calls. I said, I can give you the answer tomorrow if you do the 24-hour video EEG tonight. But it's, the parents and I, we are a team, and we try to advocate for those testing. And in terms of treatment, as you say, you wish it was more, it was faster. So the first thing I do is look at what's causing the epilepsy, what's causing the autism, what's causing the regression. Once I find that out, and let's see, I do genetic studies, and if I see a genetic mutation or a deletion, I go to the literature and I look at what are these kids with these mutations, what medications work for them. And that is the first medication that I would try. And if they have a structural abnormality in their brain, they call me, I'm aggressive towards epilepsy surgery. And I don't shy away from that label because to me, unfortunately, epilepsy surgery for structural epilepsy is the only cure for epilepsy. So yes, I will be aggressive in getting my patients that treatment if that is the appropriate treatment for them. So I'm so glad that you guys are forming a group. We need a group. And if there's anything I can do on my end, I would certainly love to be an advocate and to support you.
Another question.
Yes.
What about those who've missed those window of opportunity? Because it's always about let's stop the spikes, let's stop the spikes. Okay, the spikes are down to 5%. We need right now is cognitive rehab therapy immediately, and we need to know what a better life for the ones who've missed those window of opportunities because we can't.
So the good thing is the brain continues to develop throughout our lives. And I have looked at the data. It's like, at what age is plasticity, meaning the brain adapts the most, is able to overcome things? So between 7 to 9 years old, that's a maximal plasticity. So if the child presents at 5, we start the treatment and we get to the answer at 7. So those first 2 years, between 7 to 9, those are optimal recovery stages. So I am optimistic about that. But for those who missed that window, just as I've said before, I've seen one child with epilepsy. I've only seen one child with epilepsy. The ability of the brain to adapt, the ability of a child's brain to learn new things and to compensate for what they've lost is also immense. So I am still optimistic.
What's the percentage of recovery that you've seen? So how many IQ points once a child gets into remission, have you seen like the greatest amount?
For the ones, so I typically do neurocognitive testing, neuropsych testing before I start treatment. So once I start high-dose Keppra or benzos, I do baseline neurocognitive testing. And then once they've escalated the treatments, so after steroids, I do testing again. If, let's say, if the ESES disappears, I do post-treatment testing. And I cannot give you the exact number, but in terms of norms, sometimes they go back to normal for age. So it's very impressive the way they keep up afterwards, after you've treated it. So 7, between 7 and 9.
If they're treated immediately.
Right, if they're treated within that 2-year window. Right.
That.
It's, I'm sorry, yes?
So you usually treat ESES with benzos. My child has a paradoxical side effect. So whenever we give her benzo, she doesn't have ESES, but she is at risk for developing it. But whenever we give her benzos, she has like a stimulant reaction. It wakes her up, and I'm nervous if she were to develop it and we treated it with benzos, then it would affect her sleep. She wouldn't be able to sleep, and then I know how important sleep is for the body, for the brain. Like, how would you treat that the same way?
No, I see you're wearing a KCN82.
KCN2, yes.
Yes. So just as I have mentioned before, I usually look at their mutations, and then I look at what's been reported to work for their mutations, the pathogenic mutations, and that's what I treat them with. I just don't do blanket benzos,
Okay.
right? Unless your child does have ESES on the EEG pattern itself.
She doesn't,
She
but
doesn't.
her neurologist wanted us to proactively, she considered proactively prescribing clobazam to prevent her from getting ESES, and she's always on the lookout that this is something she may develop. But I said no, I don't want to give her that, and because I know, but within the KCNA2 community, I know it is something that is common, and it seems like every single person with KCNA2 is extremely different. Even with the same diagnosis, there's just such a wide spectrum, and different medications work. There's no one common medication that's more effective. Even when they all have, not everyone has ESES with KCNA2, but there's just no common treatment. Everyone has like a different reaction to everything.
Right, I understand that. That's why it makes it very challenging for the parents and for the epileptologists. Plus, usually, most kids don't just have one mutation. They may have multiple mutations, and then you may have variants of uncertain significance. So I try to be intentional about the medications that I use. I look at the mechanisms of action. So let's say if a sodium channel blocker is not helping, I'm not going to try another sodium channel blocker. I may try another medication with a different mechanism of action. And then I look at the mutation and see which channels are affected. So if it's a different channel, then I may see what's the effect if you block that channel. It may even worsen the situation. It may even worsen the seizures. So it takes a lot of steps to get to a treatment sometimes, and it takes more time. But I know the parents help me a lot. They come in with what they've read, and then we look through it. And sometimes there are resources that they have that I do not have, and I look at it. So to me, it's always a team approach. So I work with the families, and then I don't know what other medications your child has as well. So you also have to look at that. What are the other medications? Can the medications work synergistically, or can they amplify certain side effects? So that's another thing.
You mentioned genetic, you go back to the genetic. What happens if your child has 4 genetic mutations and they don't know anything about it, like any of them? They just don't know anything. It's not on that list, and
Right.
they know nothing. So your child's the only one in the world with this, and then what do you go? Where do you go to? Where do you do now?
So I always try to go to, I try to talk to my genetic colleagues. Once a year, I attend either a metabolic conference or a genetic conference, because that's not something as a neurologist that I'm always up to par with my colleagues, and I learn from them and I ask them. So I actually go on PubMed, or I think for if you don't have PubMed, you could go on Google Scholar and then look, just you type in the gene, you type in the mutation, and it will kind of have an address, like which part of the sequence is the mutation. You type it in, and usually it will come up with primary papers where these mutations have been studied. And I tell the parents, get a copy of the full report, because the full report will say on one of those fine print if they will look at the results again to see if there are new pathogenic mutations for the same region that has been reported. So we call it re-querying, meaning asking the question again for the VUSs. Parents almost have to become like doctors, right? Because you need to be aware of what's out there, the new treatments. I think this is a great time for pediatric epilepsy and child neurology, because diseases that we never thought could be treated are now being treated. I think the advancement that neuromuscular is having, epilepsy is heading there too.
So what do you see in the future? So it stopped at immune modulators, right?
Mhm.
Treatment. What do you foresee beyond that? You've drawn everything on that list already.
Right.
What next? What can we do?
To be honest, I think epilepsy surgery and neuromodulation and precision medicine. I think those three things are the forefront, and that's my dream, to be a frontliner in those new therapies. Because I don't think this is just an immune story. I don't think this is just a genetic story. This is a structural story, cellular, from the brain itself. And if there's a way for us to affect the way the signals are transmitted, because that's what seizures are, right? The synchronization of all the discharges. So if there's a way for us to interrupt that, I think that's where neuromodulation comes in. And the thalamic involvement, I really think that there is a role for DBS in ESES.
So what I'm hearing is you're saying structurally change the brain to address this as opposed to hitting it immunologically, or?
I think so. And I know right now I'm in the minority, because what's been done in the past was steroids and IVIG, but that's how you move the needle in the field, is you think differently. I'm so excited to go to CHOC because they are very supportive of their neuromodulation program. So I think it will be a great step. Yes?
I have a question. My daughter she had the EEG, and they diagnosed her with the ESES. She also has duplication 15 syndrome. So she's having the hyperactivity, impulsivity, and aggression, but she is gaining skills. She's not being medicated at this time. So do you think that's an appropriate diagnosis, or they need to look at it again?
So just as what I had mentioned in my summary, ESES is a electrical diagnosis, right? It's the EEG pattern. Did they give you the spike wave index? Is it greater than 50%? You don't know? Okay. So that's sometimes the epileptologists or the EEG readers are shocked when my patients would ask them, so what's my child's spike wave index? And they're like, let me go back and check that. But that's what gives me an idea of where they are in the spectrum, right? If it's greater than 50% or if it's greater than 80%, I think, is it ESES, is it not ESES, and how severe is it? But also the question is she having a lot of seizures during the day?
She was having drop seizures 2 to 3 times a week. That stopped. We did the overnight EEG, and that's when they said it was the ESES.
Okay. But you said she's learning. She is gaining some skills.
She's intellectually disabled, but she is gaining skills.
She has gained skills. Right, so that is a very good question because I have given this talk to the Persist Grand Rounds, and one of the epileptologists did ask me, the EEG shows ESES, but the patient is gaining skills and the patient is not having seizures. So what do I do? In that case, I monitor the EEG, so I would repeat the EEG. If they're gaining skills, that's our goal, right? For them to gain skills. Then sometimes I tend to keep them on Keppra because that's the first line that I have. And if at least I could just keep things stable, then I do that. But I know the challenge there is if they're already hyperactive, Keppra can make the hyperactivity worse. So I do the combination of pyridoxine, vitamin B6, and the Keppra.
The genetic syndrome and the autism could also be making the child hyperactive and aggressive also, right?
Right. So ABA, I utilize ABA or behavioral therapies to help with, it can help both with the autistic behaviors as well as the hyperactivity, aggression, and irritability. Yes.
Thoughts about amantadine, what are your, you're smiling.
I'm smiling because I haven't used it, but
Okay.
it is one of the things that I have consulted my adult colleagues in terms of their experience. So I think if I have gone through the medications and the immunotherapy, if a surgical candidate, if I've done the epilepsy surgery workup and they're not a surgery candidate, and I'm left with nothing, certainly, and the parents are willing to be my first patient treated on amantadine, then certainly I'm open to it. Yes. Yes.
Our daughter's EEG is at about 30% spike waves. Is there ever any hope of getting down to 0, or is we should be happy with the 30? Because we've been told it's controlled at 30, but she's not presenting the way she was before the onset of this disease.
What was it before?
It was
At
started,
baseline?
the baseline.
It got up to 90.
90. So from 90 to 30?
Well, it was slow.
Yeah, it started-
started
50 to 60, and it
just
dropped up to
increased.
85 to 80. When we were trying different treatments, and then when we went to Capra, that's when it dropped down to 30.
30. And what's the dose of the Keppra?
6.
60?
That's
6.
6 milliliters twice a day.
Oh, 6. What's that in mg per kg per day? What's what is it in milligrams per kilogram per day?
Oh, I would have to
Okay.
look at the spreadsheet, but she's 7. She's almost
She's
at the
almost
max of what she
At the max of what she can. Okay.
She can take a smidge more. But
A smidge more.
She's at the max.
Okay. Because I would defer to your epileptologist, but for some of my patients, when I'm at below 50% and they are gaining some skills, some, but not all,
Yeah.
then we have this discussion, do we push the Keppra higher? And usually 60 mg per kg per day, that's how high I would push. And if there's no improvement with the highest dose, it's still at 30%, then I may add a benzo.
I guess the question is that the consensus is at 30%, that's considered under control then? Or it just really
Unfortunately,
depends?
if you read different papers, even what percentage is considered ESES varies.
Yeah.
Some papers say greater than 50%, some papers say greater than 80%, but most of them usually are greater than 50%. So since your child is at 30%, I cannot fault your epileptologist for saying that we're okay at staying here. Because unfortunately, you just don't treat the EEG, right? You have to treat the whole child.
So even though her behavior is not equivalent to where it was before, that's just her personality?
It's possible, has the genetic testing come back?
No,
No known. Are there any
There's no-
VUSs?
and there's no, the MRI is clean.
MRI is clean, and there's no VUSs, variants of uncertain significance.
No.
No? Okay. So one of the reasons I started attending metabolic conferences is because my unknown cases of etiologies, meaning cause of epilepsy, started to be bigger, the lists. And then I said, what have I not looked at? And then I realized it's the metabolic mitochondrial disorders that I haven't looked at. So I think sometimes if you see a regression or involvement of other organs, such as GI, for example, or allergies or bleeding problems, then it may be worth looking at either a metabolic component or a mitochondrial disease, especially if they're female. But it's good that the MRI is normal, yes. And sometimes they may not like it, but I sometimes ask for a second read by a neuroradiologist in your institution just to make sure that everything is normal. And then usually most of the epileptologists, we read also the MRIs and we look at it slice by slice. Because what may be called normal by one person may not necessarily be normal. Any other questions, comments?
So my son's on Vimpat and clobazam, or clobazam spedema. So we had to put him on CBD THC to get him to sleep. He's also on amantadine. He's also getting OPIG. He's had a round of steroids. So you're thinking, after all of that surgery would be the next step?
What's the spike wave index?
Right now we're down. Well, as of August 8th, we are supposedly less than 5%.
Less than 5%. And what's your child's developmental gains? Has it improved, plateaued, or went down?
Well, when he started with this disease, he was 85 IQ. Now he's down to 51. He's not really moved since.
What's his MRI?
Clear. Near seronegative. But
Normal MRI?
at normal MRIs and seronegative, CSF and blood too.
For they checked all autoimmune antibodies. What about genetics?
The 4 genetic mutations that they don't know anything about.
What are they?
MAP4K5, HDAC4, 2Q37.3. Missense and friendship.
Makes sense. So as I have mentioned earlier, the chromosomal abnormalities, the deletions, the
Hypogammaglobulinemia as well. Hypogammaglobulinemia.
hypogammaglobulinemia. So I think it's worth re-looking at why is there hypogammaglobulinemia, and I think your child has autistic features, correct?
Yes.
And why is there epilepsy? Is there an
Liver
overlay?
inflammation as well.
Liver inflammation
And cardiac.
and cardiac. So I think this would be a case, if I was the primary epileptologist, to ask for help from my metabolic colleagues.
He's on level carnitine.
Mm-hmm.
And carnitine as well, and some mitochondrial.
Cocktail.
Yes.
They do.
Yeah,
Okay.
yeah.
Did they do a metabolic profile?
You mean the amino acid, that one? Or which
Mm-hmm.
one? Yes.
And CSF, lactate, pyruvate, acyl carnitine profile, urine organic acids, plasma amino acids.
I don't think those, no.
Okay. So I think this is the case where I would want to ask for help for additional metabolic workup and consider mitochondrial workup.
Thank you.
Okay, thank you. But please speak with your primary epileptologist, your neurologist, because they know your child more than I know your child.
Thank you.
Yes, thank you.